Hi, this is Philip Pador, founder of NCLEX-RN 45-Day Challenge. In this video, I'm going to be talking about the pharmacology of antihypertensive drugs. So let's get right into it. Hypertension or high blood pressure is a quite common disorder affecting many people who typically don't even notice any symptoms. Now, in order to gain better understanding of pharmacology of antihypertensive agents, first, we need to review a basic physiology of blood pressure. So when we talk about blood pressure, we are generally referring to the force or tensions of the blood pressing against the artery of walls. Now, this pressure in the arteries is maintained by, among other things, like contractions of developed ventricles, systemic vascular resistance, elasticity of arterial walls, as well as the blood volume. In other words, blood pressure is simply a product of cardiac output and systemic vascular resistance. There are a couple of major systems involved in blood pressure regulation. First, arterial blood pressure is regulated by pressure-sensitive neurons called baroreceptors, located in the aortic arch, carotid sinus. So for example, if a blood pressure falls too low, those beta receptors can send signals to the adrenal medulla, causing release of catecholamines, and thus increase in sympathetic activity through activations of alpha and beta receptors. So activations of beta-1 receptors cause increase in heart rate and stroke volume, and thus increase in cardiac output, which leads to increase in blood pressure. On the other hand, activation of A1 receptors on smooth muscles causes vasoconstrictions and thus increases in vascular resistance, which again leads to increase in blood pressure. Now, other major systems involved in blood pressure regulation is the renin-angiotensin-aldosterone system. So we also have baroreceptors in the kidneys that respond to fall in blood pressure or reduction of blood flow by releasing enzyme called renin. Additionally, renin secretions also stimulated by sympathetic actions of beta-1 receptors in the kidneys. Now, renin is necessary for the productions of angiotensin II. Angiotensin II is a very potent vasoconstrictor which constricts systemic blood vessels and thus increasing peripheral resistance. Angiotensin II also constricts renal blood vessels and stimulates aldosterone secretion, which leads to sodium and water retention, thereby increased blood volume by cardiac output, and ultimately increase blood pressure. Now, let's switch gears and let's talk about antihypertensive agents. So there are several major classes of antihypertensive drugs, which work by interrupting different parts of this blood pressure regulating systems. First, we have the A1 blockers, such as the doxazoxine and the prazosin, which block A1 receptors on the smooth muscles, thus causing decrease in the systemic vascular resistance and ultimately decrease in blood pressure. Next, we have the selective beta blockers, such as atenolol and metoprolol, which selectively blocks beta-1 receptors on the heart, thus causing decrease in the cardiac output and thereby decreasing blood pressure. As you may remember, we also have a non-selective beta blockers, such as the labetalol and the carvedilol, that can additionally block A1 receptors and thus simultaneously decrease vascular resistance. Furthermore, beta blockers can inhibit beta-1 receptors present on the kidneys, and thus suppress the release of renin in the formations of angiotensin II and the secretions of aldosterone. So these effects result in the decrease in systemic vascular resistance and again fall in the blood pressure. Now, the next major class of antihypertensive agents are centrally acting adrenergic drugs, which work by blocking sympathetic activity within the brain. Examples of drugs that belong to this class are clonidine and methyl-dopa. Now, clonidine selectively stimulates presynaptic A2 receptors, thus providing negative feedback to reduce catecholamine productions and release. This leads to decrease in systemic vascular resistance and cardiac output and ultimately decreased blood pressure. Methyl dopa, on the other hand, also lowers blood pressure through the same mechanisms. However, unlike clonidine, it is not an agonist itself. So first, it must be converted to its active metabolite called methylepinephrine. Now, let's move to another major class of antihypertensive agents, that is a calcium channel blocker. So, calcium channel blockers are divided into two main subclasses: the dihydropyridines and the non-hydropyridines. Now, the dihydropyridines selectively inhibit L-type calcium channels in the vascular smooth muscles. Under normal conditions, when the calcium enters a smooth muscle cell, it causes it to contract, which leads to the increased vascular resistance and thus increase in blood pressure. So when dihydropyridine drug blocks the entry of the calcium into the vascular smooth muscle cell, the contraction is inhibited, which leads to the decrease in resistance to blood flow and thus lowering the blood pressure. Examples of drugs that belong to this group are amlodipine, felodipine, nicardipine, and the nifedipine. When it comes to the side effects of the dihydropyridines, they are related to systemic vasodilations. So you can expect dizziness, headaches, flushing, and peripheral edema. Another side effects that may occur with this class is the swelling of the gums, also known as the gingival hyperplasia. Now let's move on to non-dihydropyridines, which are the non-selective inhibitors of the L-type calcium channels. In other words, they are not only capable of blocking calcium channels on the vascular muscles, but also calcium channels on the cardiac cells such as those of the SA node and the AV node, which leads to the reduced myocardial contractility, slower heart rate, and slower conduction. That's why this agent exhibits significant antiarrhythmic properties. Now, it is important to remember that even though the decreased heart contractions typically results in the decreased cardiac output, non-dihydropyridines do not significantly decrease cardiac output, most likely because of the reflex tachycardia that occurs as a result of the vasodilation. Currently, there are only two drugs that belong to this group, namely diltiazem and verapamil. Now, when it comes to the side effects, non-dihydropyridines can cause excessive bradycardia and cardiac conduction abnormalities, can exert significant inhibitions of calcium channels in the smooth muscles that lines the GI tract, which can lead to constipation. Now, the next major class of antihypertensive agents are diuretics. There are three major classes of diuretics that are used in the treatment of hypertension. First, we have the loop diuretics, such as the furosemide, which work by the reducing of the reabsorption of sodium chloride in the kidneys, leading to the significant diuresis. With less volume in the vascular space, the less blood returns to the heart, so cardiac output is decreased. This in turn leads to decrease in blood pressure, particularly in the patients with volume-based hypertension and chronic kidney disease. Secondly, we have thiazide diuretics, such as the hydrochlorothiazide, which also reduce reabsorption of sodium chloride in the kidneys, but to much smaller degree than the loop diuretics. This leads to the initial decrease in the intravascular volume, decrease in cardiac output, and ultimately lowers the blood pressure. However, the long-term effects of the blood volumes are minimal, and sustained antihypertensive effects are thought to be produced by the thiazide-induced vasodilation. Lastly, we have the potassium-sparing diuretics, such as the triaterine and the spironolactone, which increases diuresis by either interfering with the sodium-potassium exchange in the kidneys or by blocking the actions of the aldosterone. Potassium-sparing diuretics are often used in combinations with the loop and the thiazide diuretics to reduce the loss of potassium that can occur with the use of these drugs. Now let's move to another group of antihypertensive agents. That is the agent that works on the renin, angiotensin, aldosterone system. So here we have three pharmacological targets that can be used to reduce the activity of angiotensin II, which is ultimately responsible for causing blood pressure to increase. First, we have renin, the enzyme responsible for conversion of angiotensin to precursor of the angiotensin II, that is angiotensin I. So renin is a target of renin inhibitors which selectively inhibit these enzymes, thus decreasing productions of angiotensin II. Example of drug that belongs to this class is aliskiren. Secondly, we have angiotensin converting enzymes that is responsible for conversions of angiotensin I to angiotensin II. This enzyme is a target of ACE inhibitors, so just like inhibitors of the renin. Inhibition of angiotensin converting enzymes also leads to decreased productions of angiotensin II. However, what makes ACE inhibitors different is that in addition to the lowering of angiotensin II levels, they can also elevate the bradykinin levels. Bradykinin is a peptide that causes blood vessels to dilate by stimulating the release of nitric oxide. However, normally, angiotensin converting enzymes inactivate bradykinin, so its inhibition leads to the bradykinin-induced vasodilation. The examples of drugs that belong to this class are benazepril, captopril, enalapril, lisinopril, quinapril, and ramipril. Finally, we have angiotensin II receptors type 1, or AT1 receptors for short. So binding of angiotensin II to these receptors is actually responsible for most of the effects of angiotensin, including vasoconstrictions and stimulations of aldosterone release. These receptors are the target of the angiotensin II receptors blockers, or the ARBs for short. Examples of drugs that belong to this class are candesartan, irbesartan, losartan, and valsartan. So in summary, the agents that works on these angiotensins and the aldosterone systems either block the productions of the angiotensin II or block its actions on the ATI receptors. This in turn leads to the decreased systemic vascular resistance, but without significant changes in cardiac output. Additionally, these agents reduce the effects of angiotensin II and the renal hemodynamics. Specifically, angiotensin II constricts the efferent arterioles, thereby generating back pressures in the glomerulus, which can lead to injury. So by reducing activity of angiotensin II, these agents also improve renal blood flow and thereby reduce the risk of renal injury. Now, when it comes to the side effects, because these agents suppress aldosterone release, their use can contribute to the development of the hyperkalemia. Furthermore, ACE inhibitors in particular may cause dry cough or, in rare cases, angioedema, which can be life-threatening. This is thought to be due to the increased levels of the bradykinin and substance.